We talk a lot about blocked arteries, the plumbing that brings blood out, but what about the veins, the ones bringing it back?
Exactly. They can get blocked too. And today we're diving into something called Iliocaval Venous Obstruction. It's surprisingly common, but often missed.
Like a big traffic jam in the main veins, draining your legs and pelvis,
Well, that's a
right?
good way to put it. And we're going to unpack this using some really key chapters from Rutherford's vascular surgery and endovascular therapy, focusing on the newer endovascular treatments.
So for you listening, our mission today is pretty straightforward. Get you up to speed on this condition, what it is, how doctors spot it, the latest treatments, no information overload, just the key stuff, those aha moments.
And we'll focus on the two main players here: non-thrombotic iliac vein lesions,
Hmm.
NIVL, or you might know it as May-Thurner syndrome, and post-thrombotic iliac vein stenosis, PTS.
Okay, let's jump right into May-Thurner, or NIVL. Sounds a bit mysterious. It started way back, didn't it? Like early 1900s?
Yeah, 1908. A doctor, McMurrich, noticed these odd sort of web-like things inside the iliac veins.
And people weren't sure where they came from initially. Born with it? Or...
Right, that was the debate, onogenic versus acquired. But the thinking now, the widely accepted view, is that it's acquired.
Acquired how?
It seems to be from the constant pounding, basically.
Mhm.
The artery lying next to the vein, pulsating, causes tiny repetitive injuries over time, trauma to the vein wall.
Wow, like a slow motion injury. And that leads to, what, the vein changing?
Exactly. You get increased wall thickness, sometimes membranes form, these webs, even fibrous strands inside the vein.
So calling it just iliac compression syndrome is a bit incomplete.
Yeah, it really is. Compression is part of it, sure, where the artery crosses over, but the lesion itself is often more complex than just a simple squeeze.
And this compression thing, it's surprisingly common, isn't it? I read something like maybe 2/3 of people might have some degree of it.
That's what modern imaging, especially IVUS intravascular ultrasound, is showing us. It might be present anatomically in, yeah, maybe up to 2/3 of the population, which is kind of staggering.
Hold on, 2 out of 3 people might have this, but most don't have symptoms. How does that work? Why only some people?
That is the big question. It seems this anatomical setup only becomes clinically significant, causes symptoms, in a smaller group.
Who tends to get symptoms then?
We often see it more in younger women, and typically it affects the left leg more than the right. And importantly, this underlying lesion can sometimes be the trigger for a deep vein thrombosis, a DVT.
So it lurks silently for most, but for a few, it's a setup for trouble like DVT. How did they even diagnose this before things like IVUS venography?
Yeah, venography was the main tool, injecting dye, taking x-rays. But we know now it wasn't great for these kinds of lesions, maybe only 50% accurate.
Only 50%, wow.
Yeah, it could easily miss these compressions depending on the angle. The real game changer was IVUS. It gives us a direct look inside the vein. Sensitivity is over 90%.
That's a huge difference. So with IVUS, we see this compression as common, but symptoms like leg swelling or even ulcers, they often need a second hit.
Precisely. Most lesions are silent. Symptoms often pop up when something else happens. Trauma, maybe an infection, pregnancy, or like we said, a DVT forming there. The underlying lesion creates a vulnerability.
And these May-Thurner lesions, they're usually quite localized, right?
Right.
Where the artery or maybe a ligament is pressing.
Typically, yes. Focal points of compression.
Okay, that makes sense for NIVL. Now, what about the other side of the coin PTS, post-thrombotic stenosis? This comes after a DVT.
Exactly. It's the scarring and damage left behind after a blood clot in the iliac veins.
And you're seeing this just as often as NIVL now?
In major centers, yeah, the incidence is roughly equal.
Yeah.
And it's probably increasing, or at least we're diagnosing it more because we're better at detecting those initial iliac DVTs with imaging like CT scans and ultrasound.
So NIVL can cause a DVT. PTS results from one. Are the blockages themselves different in PTS?
They tend to be, yes. PTS lesions are often longer, involving more segments of the vein. The clot causes more diffuse scarring, narrowing. It's not just a single pinch point usually.
More widespread damage from the clot itself.
Right, though you can still have focal narrowings within that longer segment.
Is there anything like unique to PTS lesions? I think I saw something about Rokitansky stenosis.
Ah, yes, Rokitansky stenosis. That's a specific type where you get this long sort of fibrous sleeve forming around the vein. It can be tricky because on a standard venogram, it might not look that bad unless you actually measure the pressure or diameter inside. It can kind of fool the eye.
Okay, so whether it's NIVL or PTS, you end up with a blockage. And that blockage often comes with another problem, reflux, backward flow.
Very often, yes. Especially reflux happening below the groin. The combination obstruction plus reflux leads to what we call peripheral venous hypertension, high pressure down in the leg veins.
Bad combo, blockage and blood flowing the wrong way. What does that do to the leg tissues?
It causes microvascular injury, damage to the tiny blood vessels. And recent work suggests the central obstruction is more linked to high pressure when you're lying flat,
Okay.
while the reflux seems more tied to high pressure when you're upright, standing, or walking.
Huh. That's specific. And what about that ambulatory venous pressure, the pressure when walking?
That seems to get worse as the reflux gets worse. It's less directly tied to how bad the obstruction is, interestingly enough.
Yeah.
More about the reflux component.
The body tries to compensate, though, right, with collateral veins. Find detours.
It does. We all have these potential alternative pathways, but they usually stay quiet, dormant, when the main iliac vein is wide open. If the main channel gets blocked and pressure builds up, blood will try to find these collateral routes.
Like nature's bypasses. But are they any good? Can they really replace a big vein like the iliac?
Well, think about basic physics, Poiseuille's equation. Flow is incredibly sensitive to the radius, the width of the tube, its radius to the fourth power.
Right. Small changes make a huge difference.
Exactly. So you need a huge number of tiny collateral vessels to equal the flow capacity of one large iliac vein. It's very rare for collaterals to fully compensate for a significant iliac obstruction. The resistance is just too high.
How much does a little narrowing matter?
It's actually quite dramatic.
Yeah.
A narrowing of the common iliac vein by just 12%, say, from 16 millimeters down to 14, can nearly double the resistance to flow.
Wow, just 2 millimeters makes that much difference.
It really highlights how critical these main venous pathways are.
Okay, shifting slightly. There was a mention of the lymphatic system being involved. How does that fit in?
Yeah, that's a really interesting connection we're understanding better. It seems lymphatic dysfunction problems with draining tissue fluid is found in maybe 30% of limbs with chronic venous disease.
Why? Is it related to that microvascular injury again?
That's the likely culprit. The high venous pressure and inflammation probably damage the tiny lymphatic vessels too.
And can fixing the vein problem help the lymphatics?
Sometimes, yes. It's quite fascinating. Studies show that in about a quarter of patients who have iliac stenting for venous obstruction and also have lymphatic abnormalities, those lymphatic issues actually get better after the stent.
Wait, really? Stenting a vein can improve lymphatic function? That's unexpected.
It points to a real interplay between the venous and lymphatic systems that we're still exploring.
Okay, so we know what these blockages are and what they can cause. But who actually needs treatment? Since that compression can be so common and silent.
Right. Crucial point. Chronic venous disease itself usually isn't life-threatening. And if you have one of these lesions but zero symptoms, you absolutely do not need prophylactic treatment. No way.
So treatment is only for people with symptoms?
Yes. And the first step is always conservative management. Compression therapy stockings, wraps.
The dreaded compression stockings, you mentioned they often don't work, or people don't wear them.
Yeah, the failure rate is high, 50% or more. Either they aren't effective enough for the symptoms, or, more commonly, there are compliance issues. People find them difficult, uncomfortable.
And we don't really know why compliance is so tough.
It's poorly understood, honestly. Even with lots of education and support, it remains a big challenge.
So if compression fails, then you think about stenting.
Exactly. Iliac vein stenting is considered after a fair trial of conservative therapy hasn't worked. And it's important for you to understand, this is generally a quality of life procedure. It's not like a blocked leg artery where we're worried about losing the limb. It's about reducing pain, swelling, improving daily function.
Making life better, essentially. Are there specific benchmarks, like how bad do the symptoms need to be?
Generally, we look at patients in the more advanced stages of chronic venous disease. That's CEP classes 3 to 6. So significant swelling, skin changes, or active ulcers.
What about less severe visual signs but bad symptoms, like that venous claudication?
Yes, that's important too. Venous claudication leg pain, or bursting feeling with exercise, especially walking uphill or stairs, or what's called venous hypertension syndrome, that heavy, achy leg pain relieved by elevation.
Yeah.
Those can be indications even in lower CEP classes if they're really impacting the person.
And other types of pain, like cramps or restless legs.
Definitely. Atypical pain like bad nocturnal cramps, restless legs, or even just a persistent dull ache, especially at night, that isn't relieved by elevation, if these are significantly limiting lifestyle or sleep, they could be reasons to investigate and potentially intervene. We use tools like pain scores, VAS, and the Venous Clinical Severity Score, VCSS, to quantify things.
Sounds like a very patient-centered decision. Are there specific groups who particularly benefit?
Yeah, several groups come to mind. Elderly patients who physically can't manage compression stockings, obese patients with severe venous issues where weight loss surgery isn't an immediate option, people getting a recurrent cellulitis, those leg skin infections linked to the swelling, and also patients who have an acute iliac DVT where we suspect an underlying stenosis caused it. After we remove the clot, waiting a bit and then stenting that stenosis can prevent recurrence.
You also mentioned lymphedema earlier and how it can be misdiagnosed.
Right, this is huge. Someone presents with a swollen leg, maybe some classic signs like swelling on top of the foot, and they get labeled lymphedema. But those signs aren't actually specific.
They can happen with venous problems too.
Absolutely, venous obstruction can cause those exact same signs. Given how common venous disease is, it's very likely that venous lymphedema or phlebo lymphedema, swelling, mainly driven by the vein problem, is actually the most common type of secondary lymphedema out there.
That's mind-blowing. So someone could be treated for lymphedema for years when the real issue is a fixable vein blockage.
Precisely. That's why it's so critical to rule out a correctable iliac stenosis before settling on a lymphedema diagnosis for treatment purposes. If you find in stent a significant stenosis, the swelling often improves, though maybe not completely if there's also underlying lymphatic damage.
Okay, and quickly, what about managing that reflux, the backward flow, when stenting?
If it's superficial reflux, like in the saphenous veins, that can often be treated before or during the stenting. If it's deep vein reflux, the usual approach is stent the iliac obstruction first. Fixing the blockage often improves the deep reflux on its own. More complex deep valve repairs are usually reserved for later if needed.
Got it. So, moving to diagnosis. Venography was the old way. What were its main problems again?
The big issue was its two-dimensional nature. These iliac lesions are often like pancakes, squashed flat. A standard front-to-back x-ray might completely miss it or make it look less severe than it is. You needed multiple angles, and even then.
Easy to miss things, but experienced eyes could sometimes pick up clues.
Yeah, experts could often see subtle signs like contrast dye lingering or lots of collateral veins showing up, but it was still prone to error.
And then came IVUS. You mentioned a study comparing them head to head.
Yes, a blinded comparison. The results were pretty stark. Venography completely missed a significant iliofemoral stenosis in 19% of limbs, nearly 1 in 5.
Wow.
And even when venography did see a lesion, it significantly underestimated how severe the narrowing actually was compared to IVUS measurements. They also often disagreed on the best place to land the stent.
So IVUS isn't just a bit better, it's fundamentally more accurate for seeing the lesion and planning treatment.
Absolutely. It lets you see the vessel from the inside, measure the actual area. That's why it's considered the gold standard now for the morphological diagnosis.
What about CT or MR venography? Do they play a role?
They can be helpful, certainly more so than standard venography because they give you cross-sectional images. You can measure diameters. CTV in particular seems quite accurate compared to IVUS in recent studies. But for the fine details needed during the procedure itself, IVUS is generally preferred.
Okay, so IVUS is king for diagnosis and planning. Let's walk through the stenting procedure itself. How do they get access?
The usual way is through the femoral vein in the mid-thigh of the affected leg, using ultrasound to guide the needle. Unlike arteries, you don't need to go over bone, and the lower pressure makes it pretty safe. Less risk of major bleeding or bruising.
And they use a slightly bigger access tube, a sheath.
Yes, typically an 11 French sheath. It just gives more room to work to get the balloons and stents in easily. Accessing mid-thigh also ensures you have enough space below the groin if you need to extend the stent down into the common femoral vein.
Makes sense. Once they're in, what are the key steps?
Well, sometimes an initial venogram on the table, but the real workhorse is IVUS. You run the IVUS catheter through the vena cava, the common and external iliac veins, down to the common femoral. You identify all the narrowed areas and figure out where the healthy vein segments are for the stent landing zones.
And IVUS measures the narrowing precisely. How do they calculate the percentage?
Yes, you use IVUS planimetry to measure the cross-sectional area at the narrowest point. Crucially, you compare that area to the expected normal area for that specific vein segment based on reference values or measurements in a truly healthy section. You don't want to compare it to an adjacent, potentially also diseased, segment that underestimates the problem.
And you mentioned sometimes stenting, even if it's less than 50% narrowed.
Right, because symptoms matter most. If a patient has disabling symptoms clearly linked to the vein, even a lesion that measures, say, 40% by area might warrant treatment if pressure measurements or the clinical picture strongly suggest it's the culprit. It's about treating the patient, not just a number.
Okay. Once the lesion is mapped out. Balloons?
Yes, predilation, usually with large caliber, high pressure balloons, 16, 18 millimeters sometimes.
Hmm.
These iliac lesions are often very fibrous, tough. Simple balloon angioplasty alone rarely works long term. The vein just recoils, so you need the scaffolding of a stent.
And choosing the right stent size is critical.
Absolutely essential. You need to match the stent diameter to the normal diameter of the iliac or femoral vein segment you're treating. Undersizing the stent is a major cause of failure or continued symptoms. You basically create a new narrowing.
So, better to be generous with the stent coverage.
The principle is to treat the entire disease segment, landing in healthy vein above and below. Evidence suggests more liberal stent coverage, covering the whole length of the disease, actually leads to better long-term results than trying to be minimalist.
And for PTS, the stent often needs to go below the groin.
Very often, yes. Post-thrombotic disease frequently extends into the common femoral vein. So the stent needs to cross the inguinal ligament and land just above the opening of the deep femoral vein, the profunda. That inflow from the profunda usually helps keep the stent open.
What about lesions right up near the IVC, the big vein in the abdomen?
For lesions at the iliocaval confluence, especially if you're using certain types of stents, you often need to extend the stent slightly into the IVC to ensure the very top of the iliac vein is fully opened and supported. Sometimes a technique using overlapping stents or a stronger Z-stent scaffold right at the junction helps prevent compression by the overlying artery and keeps the pathway from the other leg open.
Are there specific stents just for veins now?
Yes, dedicated venous stents like the Vici and Venovo stents are available and designed for the forces and sizes here. They handle that confluence crossing well too. But optimizing stenting right at that Y junction, especially if both legs need treatment, is still an area of active development.
After the stent is deployed, more balloons.
Usually, yes.
Yeah.
Post-dilation with a balloon inside the stent to make sure it's fully expanded to the intended diameter. Then check again with IVUS to confirm good expansion and position, maybe a final completion venogram to look at flow. Then the sheath comes out, often using a closure device like a plug to seal the vein puncture site.
And if someone has symptoms in both legs?
An interesting recent finding is that you often only need to stent the more symptomatic leg initially. Many patients get sufficient relief, and only a small percentage end up needing the second side stented later.
Okay. What about the really tough cases, the chronic total occlusions, CTOs? Veins completely blocked for potentially years.
Yeah, those used to be strictly open surgery territory complex bypasses. But remarkably, we found that many of these, even long-standing iliac or IVC occlusions, can be opened percutaneously, minimally invasively.
Really? What kind of success rates?
Surprisingly high. Around 85% technical success for both iliac and IVC CTOs in experienced hands. It's quite amazing.
How do they even get through a completely blocked, scarred-up vein?
It involves careful guide wire manipulation, often using the stiff end of the wire to push through the scar tissue, staying within the expected path of the original vein. Unlike artery CTOs, you're not usually trying to create a new channel under the lining. Road mapping with venography helps, as do specialized catheters. Sometimes a blockage that looks awful on venogram is surprisingly easy to cross because the dye doesn't show the soft, disorganized clot within it.
How do they avoid poking out of the vein or going somewhere dangerous?
Constant monitoring with X-ray from different angles is key. If the wire deviates from the expected path, it's usually obvious. Because venous pressure is low and these chronic veins have thick walls, major bleeding from a small perforation is rare. You just pull back and redirect. The main danger zone is near the spine, going to midline riscs, entering the vertebral canal.
Yikes. Okay. Once they get the wire through.
Confirm you're back in the open IVC or the heart with dye injection or IVUS. Then dilate the channel. Often, you can go straight to the final target diameter with large balloons in one go, since rupture risk is low.
What if there are small leaks after stenting a CTO?
Small contrast leaks are common, but usually seal themselves off once you restore good flow through the main stented channel. A final IVUS and venogram are critical to make sure you have a good, wide-open pathway.
Now, what about IVC filters? Those little baskets put in to catch clots, if they're left in and cause problems.
That's an increasing issue. Retrievable filters not being retrieved can lead to IVC narrowing or thrombosis around the filter. If the IVC is blocked and there's an embedded filter, it's a tough situation.
Can you stent through them?
Often, yes. If the filter can't be removed, you can sometimes use balloon angioplasty to crush the filter struts against the IDC wall and then place stents right across it as part of the recanalization.
Does that require special precautions afterwards?
Definitely. Lifelong anticoagulation blood thinners is usually recommended after stenting across an IVC filter because you've essentially disabled its filtering function and the metalwork could potentially increase clot risk.
Speaking of blood thinners, what's the general approach after any iliocaval stenting?
It's crucial, both around the procedure time for prevention and to allow the vein lining to heal, which takes about 6 weeks. After that, the need for ongoing anticoagulation depends more on the patient's underlying clot risk factors than the stent itself.
So it varies quite a bit.
It does. There's no single standard protocol. A common approach might be low molecular weight heparin before and briefly after, maybe bivalirudin during the procedure. For straightforward NIVL cases with no prior DVT, maybe just aspirin long-term.
Okay.
For PTS, where the initial clot was provoked and the risk factor's gone, maybe aspirin too. But for patients with known clotting disorders, unprovoked or recurrent DVTs, or those who had very extensive stenting, especially for CDOs, longer-term anticoagulation with warfarin or a newer agent is usually recommended.
Tailored to the individual situation. Now, despite best efforts, stents can sometimes develop problems later, right? Like blocking off.
Yes, stent occlusion can happen. Acute thrombosis within 30 days is uncommon, mostly seen after complex CTO recanalizations in PTS limbs, often treatable with clot-busting drugs. Sometimes poor inflow can cause early blockage, requiring stent extension. Late occlusions after 30 days are also relatively rare, but again, more common in PTS.
What about stents that don't block completely but just don't work as well over time? Chronic malfunction.
That can manifest as returning symptoms. Like any bypass, you can have inflow problems, outflow problems, or issues with the stent itself. Specific to veins, inflow-outflow issues might be missed narrowings or the stent not quite covering the lesion at the confluence, maybe due to migration. Sometimes the IVC is just smaller than expected.
And problems with the stent body.
Two main things. External compression, where scar tissue squeezes the stent from the outside, kind of unique to veins, and in-stent restenosis, ISR, where tissue grows inside the stent.
Is ISR in veins the same as in arteries?
It seems a bit different. Early ISR, within weeks, is probably mostly soft thrombus lining the stent, maybe due to slower flow initially. This often responds well to balloons. Later ISR, months down the line, becomes more fibrous, harder, tougher to treat. Both compression and hard ISR are more common in PTS-CTO cases. But importantly, most complete stent occlusions seem to be sudden DVT events within the stent, not a slow, gradual narrowing from hard ISR.
That's a key difference. So follow-up is really important to catch these things. Surveillance.
Absolutely. Regular duplex ultrasound surveillance significantly improves long-term outcomes by catching problems early.
What's a typical schedule?
Usually a check the day after, then maybe 2 to 4 weeks to look for acute issues. After that, it depends. Less frequent for low-risk NIVL, maybe every 3-6 months initially. More frequent for PTS and especially CTO recanalizations, maybe every 3 months for the first year, then every 6 months. And of course, more often if symptoms return.
And if they find that hard ISR?
Management isn't totally clear-cut. Medications like silestazole might be tried, possibly anticoagulation, but their effectiveness, specifically for venous ISR, isn't fully proven like it is in arteries. Often re-intervention with balloons or more stents is needed.
Okay, after all that detail, what are the overall results? Is iliocaval stenting generally successful?
Overall, yes. Procedure-related complications are low, serious ones very rare. Post-stent DVT risk is around 3%. Long-term patency, keeping the stent open, is generally very good, but it definitely varies by the underlying condition.
Best for any.
By far. Patency rates for NEL are excellent, often well over 90%, even out to 5-6 years, with few re-interventions needed. PTS patency is lower, reflecting the more complex disease, maybe more in the 70-80% range for primary patency, but secondary patency after re-intervention is still quite good. CTO recanalization has the lowest primary patency, but still surprisingly good secondary patency.
And do patients feel better? Does patency translate to clinical improvement?
Generally, yes. Clinical results mirror the patency rates. Significant relief of pain and swelling is common. Interestingly, improvement can happen even if coexisting reflux isn't fixed. Ulcer healing rates are also good, particularly for NIVL patients and those with smaller ulcers.
That's great to hear. What about those special patient groups you mentioned? Elderly, obese?
Results are very encouraging. Stenting is safe and effective in the elderly, 80 years old, providing good symptom relief, ulcer healing, and reduced infections. especially if they can't use compression.
Good.
Obese patients also benefit, with patency in clinical outcomes similar to non-obese patients, which is important if bariatric surgery isn't an option. For those with venous lymphedema, stenting often helps significantly with pain, though swelling improvement might be less dramatic. Even with obvious femoral blockages, treating associated iliac stenosis helps, and stenting blocked IVC filters has shown good success too.
It really sounds like this has become a major tool, offering real hope for a lot of people with chronic venous problems.
It really has transformed the treatment landscape for appropriately selected patients. Safe, effective, and minimally invasive.
So, wrapping up this deep dive, Iliocaval Venous Obstruction, NIVL, and PTS is a big deal in chronic venous disease. Getting the diagnosis right, usually with IVUS, is crucial, and endovascular stenting. It's emerged as a safe, effective option for many people when conservative measures fail, improving quality of life, pain, swelling, even helping ulcers heal. Outcomes are generally good, though they vary a bit depending on why the vein was blocked.
Definitely. And it leaves you with a thought, doesn't it? Given how incredibly common that silent iliac vein compression might be, what other health issues, things we might think are unrelated, could actually be subtly influenced by these venous flow dynamics? Something to ponder, and certainly a reason to talk to your doctor about persistent leg or pelvic symptoms.